Good morning. Myself Dr. Sandip Kumar Parui, and this is my first interaction with your batch. I don't know up to how much you have reached in your basic sciences like anatomy and physiology. Now today's topic is a disease topic. So I'm trying to be as simple as I can so that you can understand. So today's topic of discussion is chronic kidney disease. Chronic kidney disease. So before going into the topic proper, I want to say something that whenever you are studying a disease, ask three questions. First is what, second is why, and the third is how. And these three forms the basic of the disease. The first one is what is the disease? Simply definition of the disease. The second one is why it is caused. In medical terminology, it is said as etiology, the causes of the disease, the reasons of the disease. Okay, and the third question is how it takes place. Again, in medical terminology, this is called pathogenesis. So whenever you are dealing with a disease, ask three questions. What, that is definition of the disease. Why, that is etiology of the disease. And how, that is pathogenesis of the disease. So now coming to the topic proper, chronic kidney disease. First what? What is the chronic kidney disease, or simply CKD? It is the structural, functional, or both type of damage to the kidney. How long? For more than 3 months. So what is CKD? It is the structural or functional or both type of damage of kidney for duration of more than 3 months. Each and every word is important. The first is structural. What is structural damage? There may be some structural change in the kidney. It may be reduction in size, it may be increase in size, and it may be loss of corticomedullary differentiation. In most of the diseases in the advanced stage, the kidney size is shrunken or smaller. In some of the diseases, especially in the earlier phase, the size of kidney may be enlarged, like diabetes, amyloidosis, etc. We will learn the diseases afterward. And it is the earliest change of any kidney disease, that is loss of corticomedullary differentiation. So these are simply the structural changes or structural damage. Next comes functional. What are the functional changes? So here is impairment of kidney function. Specifically, it is more than 60% reduction in GFR. GFR is the functional parameter of kidney. GFR means the volume of fluid filtered from glomeruli to Bowman's capsule. So we measure the kidney function by help of this glomerular filtration rate. Glomerular filtration rate. Volume of fluid filtered from glomeruli to Bowman's capsule in unit time. Generally, we measure it by minute. So, regarding the functional impairment, it is more than 60% reduction in the glomerular filtration rate. Now, the damage can be structural, the damage can be functional, or the damage can be both. But here the time is also important. These 3 months. Why 3 months? Because it is chronic. You will learn lots of chronic diseases throughout your career. So chronic means it is more than 3 months. If less than 3 months, it's no more chronic. If less than 3 months, it becomes acute. So simply acute means short term and chronic means long term. So this is the what of the disease. What is CKD? Now coming to the why of the disease, that is etiology or causes of CKD. The most common cause is these two. The first one is diabetes and the second one is hypertension. Next comes glomerulonephritis. It is the inflammation of nephrons, inflammation of glomeruli. Next is renovascular diseases. Example, renal artery stenosis. Here the vessels or the artery supplying the kidney is damaged. This is renovascular disease. The next cause is pyelonephritis. That means infection of renal parenchyma. The next one is obstructive uropathy. When the urine is obstructed at some level of urinary tract, it may be kidney, it may be ureter, it may be bladder, it may be urethra. Wherever the urine got stuck, it puts some back pressure on the kidney, and in long term the kidney gets damaged. The next one is polycystic kidney disease. Now come some rare disorders. like SLE or any other autoimmune diseases. And last but not the least, analgesic nephropathy. The popular painkillers, if you take it for long term, it may damage your kidney. Analgesic nephropathy. So, these are the etiology or why of the disease, why this CKD takes place. Now, the next question, pathogenesis or how of the disease. This is a very intricate or complicated process, how the kidney gets structural or functional damage. To be very simple, when this etiology comes, say diabetes, hypertension, glomerulonephritis, renovasculitis, whatever, when they come, they cause damage of certain amount of nephrons. Suppose there is n number of nephrons. Now, by these etiologies, half of the nephrons got damaged. Now this residual half are overburdened. They try to maintain the filtration. They try to maintain the whole renal function. Half of the nephron are damaged and half are healthy. Now these healthy nephron are trying to damage control. So naturally they are overburdened. They are hyperfiltering and as a result getting hypertrophied. They are pathologically enlarged. In long term, this results in permanent structural or functional damage that we see as chronic kidney disease. So, this is simply the pathogenesis. So, this what, why and how forms the basic of the disease. Basic of the disease. You have to learn these three things before going to the clinics or before going to the bedside of the patient. Now, something about the clinics. Stages of CKD. Now, CKD is divided into 5 stages according to GFR. The CKD is differentiated into 5 stages as per GFR. First is stage 1. Here the GFR is more than 90%. The next one is stage 2. Here the GFR is 60 to 89%. Now stage 3 is again divided into 2, stage 3A and stage 3B. Stage 3A is GFR 45 to 59%. Stage 3B is GFR 30 to 44%. Stage 4, here the GFR is 15 to 29%. And the last one, that is known as end stage kidney disease, is stage 5, that is below 15%. So why we are staging the disease? To map our treatment. Quite naturally, the stage 1 or 2 is quite a mild type of disease or early type of disease, but stage 4 5 is quite advanced type of disease, and the treatment line will be different for these two groups. So we are staging or grading the disease. Most interesting thing is that the symptoms starts from here. The symptoms starts from stage 4 or 5. Now we will see what are the clinical features. What we will see in a chronic kidney disease patient. And most important thing is that although the disease is in kidney, the symptom spreads from top to toe. Although the disease is in kidney, the symptoms spread from top to toe. Let us start from head. CNS. What can we see in case of kidney disease? What type of CNS symptoms can we see? CNS means central nervous system. You can see confusion, coma, or fit. All these results from increased urea, which ends up in uremic encephalopathy. Uremic encephalopathy. Uremic means the blood urea level is more than normal, and encephalopathy means it is causing brain pathology or brain damage. So increased urea results in increased urea level in the blood, and they result in uremic encephalopathy. The manifestations are confusion, coma, and fit. Next comes CVS, that is cardiovascular system. Here we can see hypertension, heart failure, and pericarditis. Here also a term we use, it's uremic pericarditis. So these are the symptoms of cardiovascular system. Next comes the GI system. Here we can see nausea, vomiting, and anorexia or decreased appetite. This increased urea is converted to increased amount of ammonia load, and this ammonia causes nausea, vomiting, and reduced appetite. Next comes the skeletal system. There is a spectrum of manifestation in skeletal system. As a whole, we say it renal osteodystrophy. I am coming in detail later. And the another system is blood or hematology. What we can see hematologically, that is anemia, that is reduction of RBC and hemoglobin or both, and platelet disorder. So hematologically these are seen. Now coming to the kidney proper, that is nephro. Here we can see anuria, that is loss or reduction in urine volume, nocturia, etc. And finally, as there is reduced filtration, the water gets accumulated in the peripheral organs, or it can accumulate in central organs also. We can see peripheral edema. Peripheral edema. So, although it is a kidney disease, we can see a spectrum of symptoms, a spectrum of clinical manifestation, starting from top to toe: CNS, CVS, nephrology, gastrointestinal system, hematology, all these. Everywhere you can see the manifestation of chronic kidney disease. Now, amongst all these symptoms, two are most important. One is anemia. Now, a simple question is, why anemia? The disease is in the kidney. Then, why there is reduction in the blood cells? Why? The most important answer is, the kidney produces a hormone called erythropoietin. The kidney produces a hormone called erythropoietin. The function of erythropoietin is to produce RBC or hemoglobin. So it is very clear, once the production of erythropoietin is less, the RBC production will be less and hemoglobin production will be less. As a result, there will be anemia. There are some other causes. These are reduced iron absorption from the gut, increased destruction of the RBC, uremic toxin suppression in bone marrow, platelet dysfunction, which results in bleeding. That also is responsible for anemia. And last but not the least, the anorexia. As the patient fails to eat, the iron intake is reduced. So these are the causes of anemia in chronic kidney disease. This is a very important question in your university exam. And one more important manifestation is renal osteodystrophy. Again, the question is, the disease is in kidney. So why the bones get affected? Disease in kidney, then why the bones are getting affected? Vitamin D. Vitamin D is activated to its active form 125 dihydroxyvitamin D is in kidney. The activation of vitamin D takes place in kidney. So once the kidney is damaged, there is reduction in active form of vitamin D. So whose kidney is damaged, the active form of vitamin D is less in his body. So what is the function of activated vitamin D? This activated vitamin D helps in absorption of calcium from gut. So once the active form of vitamin D is lacking, the calcium from gut will be less. There is reduction in calcium absorption from gut. So there will be hypocalcemia. And it will result in osteomalacia. It is a low calcium bone disease. Along with this hypocalcemia, there is hyperphosphatemia. Once the kidneys are damaged, there is less phosphate excretion. As a result, there will be increased phosphate retention, that is known as hyperphosphatemia. Now this hypocalcemia along with hyperphosphatemia exert a feedback on the parathyroid gland, and the secretion of parathormone is increased. That is called hyperparathyroidism. Hyperparathyroidism. As a result, there is increased bone turnover. There is increased bone turnover, and it is known as osteitis fibrosa. So we can see osteomalacia, we can see osteitis fibrosa. Apart from this, we can also see osteoporosis, osteosclerosis. All these can be seen in chronic kidney disease, and all these bone pathology collectively known as renal osteodystrophy. Renal osteodystrophy. So amongst the full manifestation. These two is very much important. One is anemia, the second one is renal osteodystrophy. Now coming to the diagnosis or investigation. How will we diagnose the chronic kidney disease? Among the investigations, one is blood test, one is imaging or picture, nuclear study, X-ray to see the bone changes, and finally renal biopsy. So these are the investigation generally we perform. So these are the investigations generally we perform: blood test, imaging, nuclear study, X-ray, and renal biopsy. So what are the blood tests we do here, and what we will get? First, complete blood count. We will get reduced hemoglobin, reduced RBC, and platelet dysfunction. They also may get reduced. First. The second one is blood electrolytes, which means mainly sodium and potassium. The potassium level is increased in chronic kidney disease. There is some potassium retention. Next comes urea and creatinine. These are very important markers of chronic kidney disease. Both the urea and creatinine level will be increased. The next one is blood calcium, phosphate, and vitamin D. So as I discussed, the calcium level will be decreased, phosphate level will be increased. So as a result of hypocalcemia and hyperphosphatemia, there will be increase in PTH level or parathyroid hormone level. And one more important thing is vitamin D. That is the main cause of this calcium, phosphate, and parathormone change. The vitamin D level is very much decreased. Apart from all this, the uric acid level is also increased. So these are the common blood tests we perform in case of CKD or chronic kidney disease. Regarding the imaging, it is mainly USG, where you can see increase or decrease in size and loss of corticomedullary differentiation. Apart from this, you can have a CT scan also. But most of the time, due to increased creatinine level, we cannot use contrast in this CT scan. Next comes nuclear scan. Two types of scans are there. One is DTPA scan and the next one is DMSA scan. It measures the function and this one measures the structure. So these are the nuclear scan. X-ray, we can see osteomalacia, And another important and interesting thing we can see, that is called a rugged jersey spine. What happens, in some part of the bone there is osteosclerosis, and in some part there is osteoporosis. So these are the porotic part and these are the sclerotic part. They form a rugged jersey like view. It is called rugged jersey spine. And finally, renal biopsy. When you want to know the cause, when there is no definite cause found, you have to confirm the cause by help of renal biopsy. Now the most important part, that is treatment. Treatment of CKD. First, treat the cause. Treat the cause. And second, treat the manifestation. So what does it mean, treat the cause? That is, suppose a person is having CKD out of diabetes and one is having CKD out of hypertension. So primarily we have to manage the diabetes or we have to manage the hypertension first. Otherwise, it doesn't matter how much or how better I manage the manifestation, it will recur. Unless the primary cause is treated well, the manifestations will continue to be increased. Okay, so we have to curb down the diabetes, curb down the hypertension, curb down the glomerulonephritis, curb down the SLE, whatever the cause. Then we have to do some symptomatic treatment. So already we have seen the manifestations: anemia, hypocalcemia, hyperphosphatemia, reduced vitamin D, peripheral edema, so how we will treat? In case of anemia, as we discussed, the main cause of this anemia is reduced erythropoietin level. The treatment of anemia in CKD is injection erythropoietin, not just simple blood transfusion. It will not work. Along with erythropoietin, you can give iron supplementation. So here we have impaired erythropoietin production. So if we have to treat the anemia, we have to provide erythropoietin from outside. Along with that, we have to provide the iron also, because that erythropoietin will make the hemoglobin or make the RBC from the iron itself. So along with the erythropoietin, we have to provide the iron also. Now regarding the hypocalcemia, hyperphosphatemia and vitamin D, we have to provide exogenous vitamin D supplementation, especially calcitriol, because this thing is deficient. The activation is hampered. So calcitriol cannot be produced. So we have to provide the calcitriol. Then the calcium absorption will be increased. Along with the vitamin D, we have to provide the external calcium supplement. And regarding the excess phosphate level, we treat it by phosphate binder or phosphate chelator. Example is sevelamer. Just know the name, we'll learn it later on. And then comes the peripheral edema. We have to go out the water first from the periphery of our body. We use loop diuretic. Diuretics are the medicines which helps the excess water to go out. Simply we call it water pill. And some other problems is also there, like metabolic acidosis. To reduce it, we give the patient sodium bicarbonate. And one more important thing in view of your university question, that is renal replacement therapy or RRT. Mainly this is of two types. One is dialysis and another is renal transplant. So these are the end resource of a physician. When we will think of RRT, what are the indication of RRT or renal replacement therapy? First one is resistant hyperkalemia. Potassium level is so much increased, but we cannot getting it down by help of optimum treatment. That is resistant hyperkalemia. The second one is severe metabolic acidosis. Severe metabolic acidosis. The third one is uremic encephalopathy. Fourth one, uremic pericarditis. And the fifth one, GFR almost 5 to 7. So these are the indication of renal replacement therapy. Here we advise a patient for dialysis or kidney transplant. And some interesting point that apart from drug treatment, we advise the patient for some dietary modification. What are these? The first one is reduced water intake. You have to say the patient, jal kom khaben. Take the water at less than 1.5 liter per day. It may be even lesser in advanced diseases. The next one is low potassium diet and low animal protein, because already the urea or ammonia level is increased in the blood. The animal protein may worsen the situation. So these dietary modifications are also important. So in a nutshell, this was the chronic kidney disease. It may be a bit difficult at this level, but along with time we will cope up. We will have the detailed concept of this topic. Thank you.